we mentioned Prosper was Pravastatin. Did we say an age group?
I don't think we mentioned Prosper yet.
Did we not mention Prosper?
I threw out, I kind of teased it, but we didn't actually mention it. So Prosper was.
Cliffhanger.
I know. Got to keep them interested. Right?
I'm interested. Hello, everyone, and welcome back to the Core Consult RX podcast. My name is Mike Corvino. With me, as always, Cole Swanson. How's everybody doing out in podcast world? Cole, how are you doing, man?
Doing great. Excited to be here on a wonderful Tuesday.
Yes, it is nice.
Kind of wish I was kayaking, though.
Yeah, it's nice outside.
Yes.
It's good weather.
I know. The weather really affects my mood, I think, which is why I always bring it up at the beginning of podcasts. But nothing else to say.
It's good to know.
Yeah.
Got a little insight.
Keep that in mind. Yeah.
Right,
Those rainy days, I'm going to be like, man, I don't feel like podcasting today.
But we're going to do it anyway because we need content.
Right. Exactly.
So, yes, it is May, and everyone, according to social media anyway, is getting ready for graduation.
It's about that time.
It's pretty cool to see everyone in their different colored wizard robes.
Wizard robes, yeah. Harry Potter costumes.
Everybody's got their different stripes on, depending on what kind of doctorate they have, which is cool.
Yeah, I think ours is like pharmacy is like a greenish.
It's like vomit green.
Kind of like your shirt, actually.
Yeah, that's why I wore it.
Exactly.
Yeah, it's a vomit green color, which is nice.
Yeah.
I'm not really sure why we have that color.
I don't know.
Who was in charge of that.
Yeah,
but
med school gets like this nice, it's like an emerald green, almost like the green screen over there in the corner. And very, I don't know, appealing to the eyes. And then we've got ours is like green. And there might even be like a little bit of like mustard yellow or snot yellow type thing on there. So
who's got blue? Isn't somebody have like bright blue? Is that like PhD of some sort?
It might be.
I can't remember.
I'm not sure. I'll find out in a couple weeks.
I do want to know, because I've seen some people, when the professors come up and they have this big ceremony when the professors walk in, I've seen some of them, they get these really awesome hats.
Oh, yeah?
I want to know how to get one of those.
What kind of, what do you mean?
I'd have to show you. It looks like a combination of like the Pope's hat and like a chef's hat. And I don't really know what that signifies.
Abe Lincoln's hat, just all together?
Oh, man. It's impressive.
So it's tall. Is it like poofy?
Yeah, some of them are pretty poofy. It looks like something that belongs in a Cat in the Hat now, like type situation, but it's on the guy's head, and he's wearing it seriously.
I don't know. I guess you have to be important for that to happen.
Yeah, I've never seen like how you get one of those hats, but I'm in the market, so if anybody knows.
I'll just wear one to graduation just because.
That would be awesome.
Yeah.
They'd be like, take that off. It'd be like super insulting. Somebody would be like way upset about that. Take the hat way too seriously. Yeah. I think you should definitely do that.
Yeah.
I thought about, we went to my brother's graduation for his associates. He's did the whole high school and college credit at the same time. So we went to his like associate degree graduation. And I was telling my middle brother, I was like, I should have worn my doctor robe just so people knew what I was about.
sat in the audience.
Just sat in the audience of the Coliseum. There's thousands of people there. Yeah, no big deal.
Then after everybody walks, you should just get up and then walk across the stage and be like, woo.
People that thought I had mental illness instead of actually being for serious. Anyways, so
there was a point to that, right?
Yes. So what we're going to do today, a little bit different than we normally do. We're going to talk kind of a little bit, just some more of an opinion, I guess, on what you should do at this point. If you're graduating or if you're about to start rotations, kind of thinking forward and where everything is going from here. We're going to give kind of our points of view based on our own personal experience. So these are by no means set in stone. These are just completely our opinions on, where you should be going or what you should be looking at or what goals you should have. Kind of from this point.
Yeah, and not just for pharmacy students, but pretty much anyone who is no longer strictly a learner. So even if you're going to residency, you are in some sense a learner still, but you're practicing at the level of your degree at the same time. So still, you're going to have to keep up with information.
Yeah, and I would definitely argue, and I've said this a lot, like on social media and all that, but I would say that if you're in the medical profession, you have basically signed up to be a student for the rest of your life. I mean, there's no way with how quickly things are changing that you can just say, okay, I'm done. I did my time.
Which there are people who do, but if you want to practice at the highest level of your license, then you're going to be a lifelong learner, basically.
Yeah. So, let's I guess jump into, and just in case that sounds boring to you and you're going to turn off, we are going to go through.
Oh, yes. There's something else
I'll let
we'll
you know.
do.
Yeah, table of contents. So we will go back through some of the lipid guidelines and also some of the clinical trials that are relevant to dyslipidemia.
And statins in particular.
Yeah. So we're going to go through all that. And that way you don't feel like you were totally gypped and if this doesn't apply to you necessarily.
Yeah.
It
and
probably
teaser,
does,
we'll talk a little bit about myopathies and just how relevant those are, and maybe even touch on CoQ10, what statins are higher risk for myopathies, because that's probably the big number one question or issue you get from patients when you're starting them or continuing them on a statin. So we'll talk about that.
So don't touch the dial.
Yes.
Or whatever else
1950
it is.
now.
They may have a dial. You don't know them.
I guess if you're in a car, it's a volume dial.
Yeah, whatever it is.
Yeah.
All right. So, Cole, what's...
Don't touch that aux cord.
Yeah. An aux cord. Who doesn't use those
Don't touch that Bluetooth.
Thank you. I was like, it's 2018. don't be...
Dude, I've still got the tape cassette thing that you stick into and it's got the...
No.
It's got the line on it with the aux cord that plugs in the phone.
Nice.
$10 from Walmart.
Classic.
Oh, yeah.
The cassette player.
99 Jeep Grand Cherokee Laredo. That's what I got. I'm a student, man.
Sometimes doing it big over here.
Yeah.
All right. So what do you want to start off? I mean, what are your kind of thoughts going forward? What have you seen that's worked for you so far? Obviously, you're haven't even officially...
I've been out of school forever, so
yeah,
I'm
haven't even
expert on
officially graduated necessarily, but I'm done with the didactic and the rotation part of school, just waiting to walk. So what is your game plan, I guess, going forward?
Yeah, I mean, I tried to, during rotations, consider what I'm going to do going forward. And I'm sure y'all have heard statistics like this, but especially in pharmacy in particular, after 5 years, they say that like 75% of the information is outdated or irrelevant. I think that might be a little overstated. All of the foundational knowledge that you have is going to continue to be the same. It's not really going to change, but a lot of it will fall out of your brain. It's just kind of how it works. And you're going to get into the mindset of whatever job you're in, and you're going to kind of be laser focused on that. Now, the drugs and treatment therapies, new clinical trials, all of that is going to change and become updated as the years go on. What I'm going to kind of try to do is say, okay, what did I do to stay up to date during rotations, and try to follow that path going forward with my job. So one thing is obviously emails and things. We'll talk about that. It's probably the easiest way I stay up to date on what new drugs are coming out and even what new clinical trials, and just try to do a little bit every day. And I think you could speak a little bit more to some specifics on that too.
Yeah, and I did put a post on Instagram a few nights ago with, I think I had 4 or 5 different websites you could subscribe to for free that I personally use and definitely recommend to students and new grads and anybody else who's trying to stay current with information. Where you pick what type of topics interest you or correlate with whatever kind of practice setting you're in, or that just in general you want to learn more about, and they will send you new literature, drug updates, new clinical trials that are in the works, new drugs that are being investigated, whatever it is. They will send those to your email, so it's very, very simple to kind of look through that, see what applies to you or what you want to learn more about, and then you can kind of dive a little deeper. One thing that I think is super, super important, and I think Cole did this very well, is just from kind of seeing him from the starting process of starting 4th year and kind of going all the way through. And so this really applies to any of you who are, getting ready to start rotations or just recently started rotations. I think that keeping in mind, even if you're in a practice setting for a rotation that has nothing to do with what you think you're going to do as a career, it's still super important that you go 100%. One of the things I always recommend for students that I'm talking with that are, first year, second year, third year prepping for rotations is pick rotations and look at every single one of them as like a potential job interview.
Yeah.
You go into the setting, even if it's something you think you will never, ever actually do in practice, you have no idea what kind of people you'll meet, what kind of influence, your work ethic or whatever it may be, may have on somebody else, what kind of impact, you working to a certain level may have on your career, very indirectly. It's too there's too many things that can happen. Too many people know too many other people that you may not think about that can open doors for you not to take advantage of that. And so, one of the things I always think about is, one of the things I noticed about Cole, and I'll just give him some props since he's obviously sitting here, because when he first started rotation with me, I didn't know who he was. I'd never really worked with him or met him or anything. And, he started rotation. And one of the things that I make all the students that come on rotation with me is I have them work, usually 14, 15-hour shifts, kind of see how they respond and make sure that, they realize that, one, they can actually do it and survive. People think that this shift that long is just way too much, when in reality you have physicians and residents that are working 36-hour shifts.
Yep.
So, a 14-hour shift is really nothing in the grand scheme of what it could be. And so I show them that one, that an 8-hour shift is nothing. You can definitely push yourself further than that. And also too, just to kind of see what kind of attitude they have just in general towards it, whether it's positive, whether it starts to get negative when they get tired, what have you. So one of the things I noticed obviously about Cole was that he had a really good attitude, but also he never decreased the amount he was actually pushing. And so he would always be trying to get after it. If it was like MTM cases, he set the record. Him and the girl, Stacy was who he was working with. Her and Cole were working as a team on some MTM, and they definitely set the record for amount of claims billed in one day.
All you had to do was tell us that there was a record, and I was like, okay, it's over now.
And what's funny is I asked Stacy about it, and she's definitely a go-getter, super, super smart, and she was saying that she had asked you, I guess, about going on lunch or something like that, and she's like, he wouldn't really respond. He was on a mission.
It's like, what are you talking about? There's a record to beat today.
And I definitely told them that they wouldn't beat the record just on a time basis, and they proved me wrong. So that was good. That was my first kind of glimpse at his work ethic and mindset. And so, when I started the core consult stuff, I had so many people that, I think are great students. I think are going to be great pharmacists, whatever, telling me that, I want to help, I want to do this, I want to do that. But, real life gets in the way. Everybody is busy with responsibilities and family and what have you. And Cole's really the only one that was still all on board, even after rotation. He'd already gotten his A, didn't need me for anything as far as that goes. And, but still kept coming back and kept helping with stuff, and it really was an asset. So when I needed to bring in a co-host for a podcast, it was a no-brainer. And when we started this up, and it's been awesome ever since. But it's because he's got that mindset of, I'm pretty sure when you started my rotation, podcasting is not on the radar for you. And
last thing on my mind when I'm starting my first rotation ever is, okay, I really need to get to know this preceptor so we can do a podcast later on.
Yeah. And it's one of those things that at least for me, it's been a good experience. I'm assuming since he keeps coming back every week.
Yeah. No, I look forward to it every time we do a podcast, so it's great.
And so it's just you just never know what's going to open. Him and I are now going to be working together with diabetes education program for the city, so he's going to be one of our newest diabetes educators. And that's, all that stuff stems from what you do on rotation. If he come in and just done the bare minimum, or just not had a good attitude at some point, or, honestly, I wouldn't have any ill will towards him, but I probably wouldn't be jumping at an opportunity to try to help him when he graduates.
Hey, you want to co-host my podcast, slacker?
Exactly. We'll probably film one episode a year. But, I just think that you have to play in mind, and it also really depends on your ambitions. There's some people whose their ambition is to make enough to live comfortably, and you want to be on a couple different softball teams and go to trivia night and all that. And I have, if you're happy and you're enjoying your life, enjoying the family life and whatever, respect. No judgment whatsoever. I don't ever expect anyone to try to go out and conquer the world if that's not their mentality. But if you have the mentality of you want to go out, you want to make a name for yourself, you want to really get a career established that is going to be growing and getting stronger as you move forward, I definitely think that every single rotation you need to look at as an opportunity to really network in real time and develop a name for yourself.
Yeah, I totally agree. And I have priorities, and you just have to figure out where your job or your career or whatever fits into your priorities with your family, your faith, or whatever it is. But another thing that I think is good to consider is when you're a student, what is your mindset like? So you're learning, you're pushing every day. A lot of people to get this A, or even some people so they can be a good clinician or provider. But a lot of it's a competitive nature to get that grade. And so maybe even, I mean, I know once you graduate, it's like, oh, great, no more grades, don't have to worry about that anymore. But create something for yourself to push you to continue to learn, whatever that might be, whether it's, okay, so I'm going to go and get this new certification or this new board certification or whatever it is in a few years. So I'm going to start studying now, and that motivates you to continue to learn a little bit every day, whatever it is. I mean, I think that's really good for community pharmacists because there's a lot of things that we can get, and some people are like, oh, yeah, those are useless. But at least it's a learning opportunity and something that could better your practice or further your career down the road. Who knows? So whatever motivates you after school, when you don't have an institution motivating you by grades, you have to create those for yourself. So just consider what those might be going forward.
And one thing I always consider too, there are so many different learning opportunities or whatever that may come along that you may think have nothing to do with your current setting. I'm actually a really big fan of going after those in particular, and the reason for that is because you really just never know what's coming around the corner or what opportunity is going to open up, or when an opportunity is going to maybe open up that you wish you were more prepared for, but you're not because you didn't take advantage of some of these opportunities that come along. And as far as learning and continuing your education, like I went to a symposium on infectious disease specifically targeting HIV and Hep C treatments. That has absolutely nothing to do with my current career path, but I do a little bit with dispensing of HIV meds, and so I was like, well, if nothing else, I'll go learn something new. I don't really know anything about Hep C, basically just the hour I learned in pharmacotherapy, and that was about it. So I really wanted to go kind of see what was up with that, and so I paid the money to go to this conference, and from there I ended up meeting a drug rep for one of the real big pharmaceutical companies that deals a lot with some of the new HIV meds and Hep C meds, and ended up from there, running back into him again, and him inviting me to come to one of the drug rep dinners. It was actually a lot smaller than I thought it was. I think it was only supposed to be for infectious disease providers.
Oh, really?
Yeah, and I was just
like, oops.
Yeah, well, he invited me to come, and he knew I wasn't, directly. He knew I was a pharmacist and dispensing and all that, so. But I had worked with him one time to get Genvoya approved, and the patient was normally getting mail order, couldn't get it, and so whenever I worked with him with the coupon code and all that, they had like this one-time override and got it basically a $4,000 med covered for free for the patient, so he didn't have to skip therapy.
Not bad.
So it was good for the patient. Helped us work together again outside of that symposium, and then like I said, he invited me to come to this dinner, and so I got to meet a bunch of infectious disease providers there. I think I've been like 5 times now to different dinners. Yeah, because you came.
Oh yeah, I came to one of those, and it was HIV too.
Yeah. So
I didn't have any idea what they were talking about. I know now though, because I have to learn it for the Naplex. But
I forgot you were with me at that. That was on rotation, but you got invited back.
That was a good meal.
Yeah, it was good. It was awesome. And I remember we were sitting. I think it was the one. No, it wasn't the one you were with me. I don't think. But there was one that I went to where I was talking to this guy, and he was actually originally a pharmacist, and now he was more on the science pharmacology side of things, the research side. And he was presenting, and he was talking about this conference he was presenting at. And I asked him where it was because I hadn't heard of it. And apparently, it's a huge conference that everyone in infectious disease knows about. But he's like, "Oh, it's in Paris," and I remember thinking like, "Oh man." I'm like way out of my class right now. I've never been asked to speak in Paris even once. And so, it's just getting to meet all these people. He gave me his email address and asked me if I ever need anything to contact him. I've met some infectious disease physicians and got to network with all these people now. Gotten great food and got to let my former students hang out with us and meet some of those people. All based on going to this symposium. Like if I hadn't just showed up that day, it never would have happened. And you just never know. And some of you have talked to me before, have heard that story. And I always just say because you just never know what's coming around the corner. And so I always look at every single opportunity, within reason to jump on it and just see what happens. Because what's the worst that could happen? You waste an afternoon.
Right.
waste $75 to get into a conference or something. There's worse things could happen to you.
Yeah, those $75 means more to some people than others.
Well, yeah, I was a pharmacist at the time, so I wasn't like a student or anything, so it's a little bit easier. It's a good write-off.
Yeah. So otherwise, as far as staying up to date, I like drugs.com is good for me, and I also use that McMaster thingy that I don't know too much about because I just set it up once, but I get the emails. Evidence alerts. Yeah, I get the emails now, so that's very helpful.
Yeah, I have the link on the Instagram post, the whole website to go to, and then you can register for a free account, and then it'll send you the emails every night if you want them to.
Yeah, and also FDA MedWatch. Oh, wait, that's a little bit different. MedWatch is like the adverse events log.
Yeah.
FDA. Look on the FDA's website for new drug updates, and they'll also send a little summary of the major clinical trials that got that drug approved, and that's really helpful to me too. Those are the main ones that I use, and of course, whatever Mike posts, I keep up with. So.
Yeah, Instagram. Medscape is another one I use. Yeah. That's free. That you can get some good email updates from. What else? Fierce Pharma is a good one. If you're interested in industry or looking at what some of the big pharmaceutical companies are up to, Fierce Pharma is a really good one. Same thing, you can get updates sent to your email. And yeah, I think that social media is going to become a lot bigger of a player as we move forward. I think that more and more clinicians and people that are very educated and very knowledgeable will start posting things on Instagram, Twitter, Alexa, things like that. And I think it'll be a much bigger role in our continuing education as the years kind of move forward.
Yeah, figure out what works for you. And a lot of people use social media, so why not use it to keep learning?
Absolutely. But yeah, that's just some things to kind of think about moving forward. The other thing is, don't be afraid to volunteer your time. I will say that that's one of the biggest things that's helped me. I think that we get fancy whenever we get licensed, and we think that we forget kind of what we did in the beginning to get us to where we're at. We forget about those steps, and one of those steps we actually paid to work. Paid a lot of money. To work a whole bunch of hours during rotations, and then like when we get licensed, we have this piece of paper that says we know stuff. All of a sudden, we're like too fancy to volunteer our time because we're just too important. And you hear people say that, well, I'm not gonna. My time's too valuable, and I'm not going to, work for free somewhere where I should be paid $100 an hour or whatever they think they're worth. That's such short-term thinking, and by proving your worth, because nobody really owes you anything just because of a piece of paper, and there's so many people out there that look just like you or maybe better than you, and I'm speaking to me and Cole too. I'm not saying by any means I'm above that. There's plenty of people that are way more qualified for a whole bunch more stuff than me, but that if you prove your worth though, and you really feel like you have something to show and bring to the table, then volunteer somewhere, volunteer at a clinic, go in and show like your worth at a place like that. You'd be really surprised at how open they are to giving you some opportunities. And then if you do prove that worth and you show your abilities, 100% you'll open up more doors than you think. It may not be all of them, and some people may say, okay, well, still don't have a spot for you, see you later. But then again, what did you really waste? You got some experience, you met some people, tried something,
help some people out
if nothing else. Yeah, it's just one of those things. You just have to think long term, especially if your ambition is bigger than just kind of doing the normal route. And if you want to make a name for yourself, you really, really, really got to start thinking outside the box of how you're going to network and increase your ability to, sell yourself, I guess, market yourself as a provider or whatever you're practicing as.
Agreed.
But, yes, so that's just kind of my 2 cents going forward.
Graduates, you just got your commencement speech from Mike Corvino and Cole Swanson. There you go. You don't even need to go to graduation now.
Yeah, it's really
taken care of.
I've heard it's overrated.
Yeah, because you didn't go.
Yeah,
so.
I was busy. So, that's a whole separate story. I cannot get myself to stand up there and walk across the stage. And I know that's like really counter to what most people think, and everybody wants to revel in that. But for me, that was just kind of, me and my wife were actually talking about this the other day, but we kind of saw graduation as really just because she didn't go to graduation either. Actually, now that I say that, we both went to the hooding ceremony. She graduated the year before me, but neither one of us went to actual graduation. And I think it partly was because like we didn't really see that as like, I guess, the finish line, so to speak. Like we saw getting our pharmacist degree as like just barely tipping the iceberg, and really the finish line or the starting point of like what really starts to kind of happen. And so for us, I was just more excited to get on with it and let's get to work. And now the fun begins, kind of thing, because now I can actually do something. Now I got this piece of paper that says I know stuff, which is vital.
Right.
And so I don't know. That's just our personal take. Most people would disagree with that, but it's what we worked for us. Plus, we were nice and cool in an air-conditioned house instead of being out with those thousands of people from all the different colleges graduating.
Outside,
That would be miserable.
Yeah.
Anyways, so cool. Would be very curious too to get anyone's opinion or strategies moving forward. So feel free to hit us up on social media and let us know if you have any suggestions going forward, or if you have plans or some new innovative way that you're going to try to market yourself or get some more experience or whatever the case may be. And we'd love to share that with people and hear about it ourselves too. So let us know, any social media platform, email, whatever you want to do. We'd like to hear about it. So what do you want to do? You want to jump into statins?
Jump into statins.
All right. I'll let you take it away.
Yeah. So we're not going to talk about all of dyslipidemia therapy. We're going to focus on statins because they are the primary form of dyslipidemia therapy. So statins, we obviously have a few of them. Most people are familiar with atorvastatin and rosuvastatin because those are the high-intensity statins. But there are others, and they would be fluvastatin, lovastatin, pitavastatin, and simvastatin. So a lot of people are also familiar with simvastatin because it's one of the older ones that has a lot of good data behind it. Most of those are either moderate or low intensity. So how does a statin work? So it's an HMG coenzyme A reductase inhibitor, basically in the cascade of cholesterol synthesis from acetyl coenzyme A, that needs HMG-CoA to metabolize it or break it down basically to form cholesterol, and it just kind of stops that. So you can't form as much cholesterol. And those are the main ones that we see. They're very potent as far as LDL lowering goes. The only thing that is potentially more potent would be the new PCSK9 inhibitors, which I think we could probably do a whole podcast on at some point too, but those are injectable. Right now, statins are really the mainstay of therapy, right?
Yeah, absolutely.
And they have some different characteristics. So as far as side effects that we think of, there's not too many common ones. You want to monitor hepatic enzymes and even look at renal dysfunction potentially. But the big one that most people complain about that you're going to hear from your patients a lot is going to be the muscle pain, myopathies, myositis, whatever you want to call it. And it can be a concern, but it tends to be a little more overblown than what we might think, right?
Yeah, big time. I think I can't quote the exact statistics, but I want to say that they say around 3/4 or so of patients who think that they're statin intolerant actually can in fact take a statin if we do some minor changes.
Yeah, I mean, if you look at the actual rates in the clinical trial, so for simvastatin, for instance, large clinical trial, at 20 milligrams, the rates of myositis or myopathy, whatever you want to call it, they are actually slightly different, but basically the same thing, was about 0.02% of the patients. At 40 milligrams, 0.07% of the patients. And 80 milligrams, which we don't even recommend anymore for simvastatin unless you were stable on it for over a year and all that kind of stuff, was only 0.3%. So extremely low, and it's extremely rare. But for patients, especially if they've been warned about it, a lot of times it can be a psychosomatic thing. Or maybe they really are experiencing it, but that doesn't necessarily mean that you just stop statins altogether for sure, but you may not even have to switch that statin over at this point yet. And some, they have differing characteristics. Some are high risk and some are lower risk, right?
Mm-hmm. And real quick too, just to mention, because you brought up simvastatin, the 80 milligram dose, the reason why we don't see people being started on, or we shouldn't see, I should say, patients being started on simvastatin 80 milligrams is because of the SEARCH trial. Showed no benefit and potential harm when you're going up to 80 milligrams as opposed to 40.
Right.
So keep that in mind. So like Cole said, unless you're already stable on it, you've been on it, then you can stay on it. But do not start any new patients on Simva 80.
Yep. And I meant to mention lipid lowering that you could expect. So within the statin groups, it's obviously going to vary. It's about 20 to 60% LDL lowering. You could expect about a 5 to 10% increase in HDL, and even triglycerides are going to lower about 10 to 33%. For LDL, nothing really beats it, like I said, except PCSK9s. You could see 38 to 72%. And while other other medications target triglycerides and can be a little bit better, you're still going to see a good decrease in triglycerides with the statins. So most of the time, you don't have to be too worried about adding something else on to really target triglycerides, even though it is done pretty frequently.
Right. And it's pretty... One of the things as far as remembering, as far as how much of a dose will have an impact on the LDL lowering, or how much more LDL lowering you can expect, there's something called the rule of 6, which says that basically every doubling of a statin dose, and this is completely an average, but you can expect a further 6% reduction in LDL. So if you're going off of guidelines that say that you should be at a certain level, certain LDL level, depending on your risk, then you know if you're a atorvastatin 20 by going up to 40 or 80, then you can kind of compound the LDL reduction based on the rule of 6s. So each doubling is 6% reduction in LDL.
Yeah, good way to remember it.
Did you already talk about hydrophilic versus lipophilic?
No.
So one of the things that to keep in mind, and there's a good meta-analysis that kind of backs this up, is to think about the actual, chemical makeup of the statin itself and how that may play a role in the occurrence of myopathies. So whether or not the statin is considered hydrophilic or lipophilic is definitely important. The lipophilic statins, those are going to be ones that are obviously going to get into the tissue a little bit more readily and could, in theory, cause more chances of having myalgias. The hydrophilic statins, not as much. And so rosuvastatin and pravastatin are the two that we think about as being hydrophilic statins. And we do technically see, according to that meta-analysis anyway, see less myalgias and myopathies with those two compared to the others. That's not the case with every single patient. It's by no means something that we have to have set in stone that we can only follow, but it is something to consider if you have a patient that's on atorva, let's say, and you want to switch them to a different one, maybe trying them on rosuvastatin could potentially help.
You would stay in that high intensity class.
Yeah, exactly.
Yeah, and a couple of things, I don't even think we mentioned, why are you worried about myalgias or myopathy? Not just for a patient's quality of life and them complaining to you every time they come in. It's because there's a risk of rhabdomyolysis, or rhabdomyolysis, one or the other. Basically, you would want to monitor their creatine kinase levels, because what can happen is their muscles can start breaking down. They're going to start spilling a lot of protein through their kidneys. It's going to cause potentially an AKI or big issues related to renal dysfunction. And then, it's going to cascade from there and you've got problems. So you want to catch it early. So that's why people, whenever they mention myopathies, you're like, oh my goodness, what's going on? But a lot of times the rates are pretty low and there are things you can do to decrease it. So one, you could pull back the dose of whatever you're on, especially if they're on a higher dose, and consider titrating them up slowly. Or, like Mike said, you could switch to something that's more hydrophilic or lipophilic. I think there's a common misconception that the higher intensities are going to be a higher risk for myopathies, but that's not what high, moderate, and low intensity means. That's all related to the lipid-lowering effect, nothing to do with the potency of the actual drug in regards to myopathy and myalgias.
Yeah, and in fact, the one that I always think about for that is the TNT trial.
Yeah.
Where they took atorvastatin 10 milligrams and compared it directly to 80 milligrams and didn't see a difference in the myopathy risk.
Right.
And in fact, I think they actually had more patients complaining of myopathies in the 10 milligrams, if I remember correctly. So it's one of those things that, we see the cardiovascular benefits from the higher strength, the 80 milligrams versus the 10 milligrams.
Right.
So, it's one of those things that I think that we overemphasize, where every student is taught to talk to the patient about the risk of having these muscle pains, muscle aches. However, we fail to realize a lot of times is, these patients will have, especially the older patients, will have body aches, will have certain muscle problems from doing just day-to-day activities, or especially if they start some kind of a new lifestyle management program where they're doing low intensity exercising even, they're going to have some muscle pains. And so if we scare our patients into thinking that, okay, if you feel muscle pain, that's literally your muscles breaking down, having an instance of rhabdo, and you need to get to the hospital, then it's very easy for people to start making the pain kind of worse than it really is in their head. So, it's something that we need to at least address, but we don't want to oversell the myopathy risk because it is very low, like Cole was saying. And as far as instances of rhabdo, even lower than that. So there's usually things we can do to kind of combat whether or not the patient has this idea that the statin is causing this muscle pain in the first place.
Right. And like you said, it is still worth addressing. So any practitioner, they're not just going to completely ignore it.
Right.
But try to tease out whether you really think this is related to the statin, and it's totally fine to get some labs and check a CK. And if that comes back okay, then you're not concerned about rhabdo. So now we're just focused on them complaining about it and what can we do there. So like we said, pull back the dose. You could even go to not even everyday dosing, a few times a week to whatever they tolerate, and then increase slowly from there to a point where they can tolerate the statin. Especially if they're indicated for a high intensity statin, then you really want them on that higher intensity statin to get it lower. Or if they're not necessarily, and you could switch to a moderate intensity like pravastatin that might be a little lower risk, then that's a consideration. Another one that's low risk is like fluvastatin, but fluvastatin is basically a low intensity statin, pretty wimpy as far as lipid lowering goes. So the ones that I really think about, my favorites are really atorvastatin or rosuvastatin because they have moderate and high intensity dosing. So if you decide that you don't necessarily want them on a high intensity yet, just need a moderate, that's up to you. But you can start them at that moderate intensity and then titrate up if you want. But there are situations where you would want to just go for the high dose, and I think that's totally fine too. Simvastatin is also fine, but that one, even though it's the highest dose you can get is a moderate intensity, is associated frequently with myopathy and has a lot of drug interactions. And then, of course, there's pravastatin, which we'll talk a little bit later on, but you might consider in your post-75-year-old patients.
Yeah. And the other thing to consider is, and this is just kind of a tactic, if you will, but if you're worried about, this patient's probably going to bring up the fact that they're having myalgias, things like that, or just really in general, because I kind of come at this as a general approach. But, with the TNT study, for instance, we saw atorvastatin 10 and atorvastatin 80. There was no starting the patient on atorva 40 and then titrating up. They jumped right to the 80 milligram dose. And so, and there's other instances of this. For instance, like post-ischemic stroke, we see that with Sparkle. They started right at atorvastatin 80 milligrams. Mm-hmm. So there's other instances like that where we've jumped right to higher intensity. The thing to consider is, at least I don't have good data to back this up. This is more just like kind of my opinion on it, but it seems a lot easier to put a patient on atorva 80 and then say, hey, guess what? We're actually going to cut your dose in half because you're having these muscle pains. We're going to get rid of those muscle pains. You're going to take half the dose you were before. So you're only doing 40 milligrams now.
Right.
That's very reasonable in the patient's mind. 80 down to 40 seems like a big jump. But the opposite is true. If they're doing okay at 40, they know that one of the potential side effects is muscle pains, things like that.
They won't want to go up.
And yeah, to say, hey, I'm going to double your dose now just sounds worse than a lot of people, especially if they're not familiar with the meds. They're just taking them because, you've told them they can cut down their chances of having a heart attack or stroke in the future. Then, cutting in half is always easier than doubling, I think.
Yeah.
And, that may not work for everyone, but.
Yeah. And it is counterintuitive to most medications that we think of, but definitely post-stroke, you want to hit them with that big one. But just in general, it seems completely reasonable. There's no reason not to. It's not like it's recommended against, and there's not really any good trial studies that say we need to titrate this slowly or you're going to have more issues. So yeah, go big or go home with statins. I like that.
Yeah. And a lot of like atorvastatin, really our data that is our good outcome data is with 80 milligrams.
Yeah,
we don't really have anything with
mortality. We don't have mortality data with 40 milligrams. Yeah.
So, if we're actually going evidence-based, 80 milligrams is what we need to be jumping to anyway.
Yeah.
So, something to consider. Recap, we have starting them on maybe the highest intensity, then backing off. We have switching them to a more hydrophilic statin if they're on a lipophilic statin, or just switching to statin in general, seeing that helps. The other thing is every other day dosing.
Yeah.
You could switch to every other day, and at least they're having, you're getting some of the benefits of a statin, and lowering the chances of having those muscle pains. So, those three things are all options that we can definitely look at as far as keeping a patient on a statin. But I think the thing that helps me the most when I'm talking to patients about this is explaining the why behind why they have to take it. And I briefly mentioned it just a second ago, but when I have a patient that's taking this, to them LDL is just a number. That doesn't necessarily mean anything. They don't feel bad when their LDL is high necessarily. So explaining the whole 10-year risk, and I did this morning with one of my new patients that I'm seeing for diabetes education. I told them we're not so worried about right now. Like you seem like a young, healthy guy now. We want to make sure that you stay this way and stay working, staying active 20 years from now, 10 years from now, to make sure you don't have a heart attack and stroke, and explain it's the long term that we're actually trying to help.
Right.
And I think that gives them some more perspective. We want to make sure that you're there for your grandkids' graduation and all that, and be able to enjoy retirement and, go fishing or whatever it is that they like. I think that it's one thing that to tell them, well, we got to get your LDL here, versus this is what can happen if I put you on this medication. We can reduce the chances of having a heart attack or a stroke, reduce the chances of death. I just think that plays such a more powerful impact on a patient's psyche, if you will, versus, hey, take this because I'm wearing a white coat and I told you to.
And we'll talk just in a second about statin benefit groups and who you want to go ahead and definitely start statin therapy in. But one trick I use for smoking cessation is incorporating the ASCVD risk calculator. So if you explain what you don't have to use those words, ASCVD risk. You pretty much always say your risk of having a heart attack or stroke. Patients can relate to that. And you can put a number on it. Over the next 10 years, this is your risk, and because you're smoking. And then if you recalculate it without them smoking, then obviously it's not, perfect, but you can say you can decrease your risk this much just by quitting smoking. And I think statins, you can put whether they are or aren't on a statin, and I feel like it might affect the calculator in a similar fashion, right?
So the newest calculator you can.
Right, the newer one.
We used to not have that, and then like when the Million Hearts study came out and all that, they did redo the ASCVD risk calculator. There's an app for it now, and they added whether or not the patient was on a statin currently, and then also whether or not they're on aspirin therapy. So those two things, they weren't in there before, and so we would get this percentage of or risk percentage, but we never knew if that was accurate or not because they were currently on a statin. We couldn't really judge that, so now we can. But yeah, that's available to download as an app.
So I haven't tested it out yet, but maybe adding or taking off the statin makes a significant difference in their risk, and that's something that you can show them tangibly.
Absolutely.
To say, hey, if we started this, then this is helping you this much. And so people like that. But as far as who you should start a statin in, there's a little bit of confusion because it's really not super recent anymore, but the lipid levels aren't as important. And so you hear people throwing that around. They say lipid levels don't matter, lipid levels don't matter. And they definitely don't matter as much, but it's mainly for a goal lipid level that you're shooting for. So you don't need to decrease it below, let's just say 60, and then you're good to go. So we don't have to increase your statin dose anymore. But how high your lipids are does matter, and it might play a role into whether you're indicated for a statin or not. So the big one is the 2013 ACC-AHA guidelines. They put out 4 main statin benefit groups, people who you should start a statin in for sure. One is patients who have clinical ASCVD, atherosclerotic cardiovascular disease. So if they've had a prior stroke or they've had a heart attack, I think that coronary artery disease counts too, potentially. Either way, if they've had an event, then they are indicated for statin therapy. And we talked about potential dosing, like just hitting them with a high dose at first and stuff like that. Number 2 is patients with LDLs greater than 190. So pretty much anybody who has an LDL greater than 190 is actually indicated for a statin. The last 2 are actually age specific. So it's patients 40 to 75 years old. The first one is patients who have an LDL of 70 to 190, and they have diabetes. So basically that's pretty much anyone with diabetes who doesn't have just like a rocker LDL. And I think that you would pretty much at this point, we're recommending statins for everybody who has diabetes for the most part. So that's number 3. Number 4 is also 40 to 75 who don't have diabetes, but their 10-year ASCVD risk is greater than 7.5%. So that's where the calculator comes into play. And those are the 4 main categories for those 2013 ACC/AHA guidelines. So there's not any goal LDLs there. It's just how high your LDL is might be a factor into whether you're indicated for statin or not.
Yeah, and so those guidelines are honestly like the ones I'm a bigger fan of, and I know a lot of clinicians have kind of incorporated that. But there is another side of the spectrum, and so, for instance, like the ACE guidelines have actually were updated in 2017. And one of the things that they kind of brought back into the mix was these goal LDLs again. They broke it down into your risk factor stratification, if you will. And so they gave specific LDL goals depending on what your risk was of having an event. And so, for instance, back before the 2013 update, we used to look at patients who, if you were on a medication like a statin, you were trying to get your LDL below 100. Unless you were at severe risk, then you below 70. We use like Framingham risk and all that. And then when the ASCVD risk calculator came out, a lot of people kind of switched to that and switched to the guidelines where, like Cole was saying, we don't really follow set LDL goals. So with the ACE guidelines, they brought back some of those similarities. For instance, if the patient is considered risk, or they actually listed as high risk. So if the patient has diabetes or CKD, stage 3 or 4 with no other risk factors, if they have, they don't have either of those, but they have 2 risk factors and a 10-year risk of 10 to 20%, somewhere in that range, then the LDL goal is less than 100. Now, what they added was they brought back the very high risk, which was less than 70, and they give criteria to meet that. But what they added was actually an extreme risk, and they said that if you have progressive ASCVD after you've already achieved an LDL of less than 70, if you have established clinical cardiovascular disease in patients that also have diabetes, CKD, then we want to drop their LDL to less than 55. So, this is something that kind of came about as a result of the PCSK9 data finally coming out, the Improve It with Zetia coming out. There's a lot of, I guess, debate around these trials in the first place. The Fourier trial with Repatha, the PCSK9 inhibitor, we definitely saw a decrease, but whether or not that decrease was substantial enough to justify the cost, that's definitely debatable. And then there's some other factors on
a decrease in LDL or decrease in mortality.
Decrease in LDL, I believe Fourier. I'd have to double check myself on this, but I believe Fourier did show.
I think it did, but wasn't that added on to
a statin?
Right, which is generally not done. It's usually people are on those PCSK9s because they're intolerant to statins, and so there's actually not really any actual data to support that at this point. Yeah. So.
But yeah, that's those new guidelines. That's one of the big arguments I've seen against them. And one of the first things I noticed was, some of the lead, authors on these guidelines were all people that were directly benefiting, necessarily, financially from companies like they're making Zetia and these, in Repatha. So you have to kind of look at that for what it is. And I'm not saying that they're wrong or not saying that it doesn't have some benefit. Obviously it does. Our a lot of times nature, human nature, you want to see a goal of something so you can see if you're getting close to that goal versus this arbitrary number and we're just kind of waiting to make sure an event doesn't happen.
Right.
That's definitely a little bit harder to judge. And I totally get the the want of a goal of some kind.
Right. And interestingly, patients want that too. You'll see a lot of patients, and they'll ask what their LDL is, and they are kind of, especially older ones, are more familiar with those old guidelines. And so they want to have a goal LDL so they can, oh, my LDL is good, so I'm fine. And so that makes it a little more difficult to increase, say, a statin dose if someone's definitely indicated for a high intensity statin at that point. And I think the whole point of what we're saying here is that a lot of the benefit, mortality benefit, cardiovascular benefit from these statins isn't about an LDL level per se, even though we know that high LDL levels are related to mortality. The lower you go, it doesn't necessarily matter. It's about being on these statins and being on the high intensity doses that has benefit. So that is to say, can your LDL become too low? At this point, there's not any data to say no, it can go too low to where there's risk. So there's really not a concern there right now either.
And we've seen, I've personally seen patients with their LDL in the teens. So, and they were doing just fine.
Yeah. So get your HDL above your LDL, and looky there, you're doing pretty good.
Crushing it.
Yeah.
So, I think that it's definitely one of those things. There's a lot of debate, and a lot of people that are much smarter than we claim to be, debating around whether or not these are good guidelines versus the American College of Cardiology guidelines from 2013. So, I think it's just one of those things. It's personal preference, and depending on the patient as well, like Cole said, whether or not you need to follow these goals. But the other thing is, if we have to measure adherence, and I think Cole touched on this too, but it is definitely a reason to pull levels and check LDLs if we think the patient may actually not be taking the medication to begin with. Definitely a good idea to get an LDL.
Right.
And kind of see.
And I mean, if their LDL is, which generally the idea is that if they're on these higher intensities, their LDL is going to be fine. So it's really going to be below those, quote unquote goals anyway. So it doesn't really matter. But yeah, if somebody is on a statin and they are just not having much lipid lowering like that you would expect, then maybe they're a special case and you might consider something different, not necessarily a specific LDL goal, but if they're still in like the 120s or 150s or whatever, even though they're on the highest dose of statin, yeah, maybe we consider adding on a PCSK9 in that instance if it's relevant. And I've actually seen, so for prior authorizations with PCSK9s, a lot of times they will say, okay, is this patient either on a highest intensity statin, but they're not at their LDL goal, or are they intolerant to statins? So in that case, you may actually have to bring out those LDL goals again to justify this to the insurance company, because they want you to specify something like that. Otherwise, they're not going to pay for a PCSK9. So if you think that it's indicated in that patient, you may have to, finagle the evidence a little bit to get the insurance companies to pay for it.
Yep. So, let's kind of, you want to just run through just some of the trials? We've already talked about some of the trials, but
run through.
Some of the other ones that have kind of come up along the ways. One of the trials I always think about is CARDS. That was patients with diabetes that were started on atorvastatin 10, and right around that same time was the TNT. So, that's where we kind of get the idea of high intensity for patients with diabetes, because we know that they benefited from having the CARDS trial showed there was a benefit of having this atorvastatin 10 milligrams. Well, there was also a big chunk of patients in the TNT trial who also had diabetes. And so if we know they benefited from 10, then we know that 80 was better than 10 in TNT. We can kind of deduce, obviously, that patients with diabetes would do better with the higher intensity. We mentioned Prosper was pravastatin. Did we say an age group?
I don't think we mentioned Prosper yet.
Did we not mention Prosper?
I threw out, I kind of teased it, but we didn't actually mention it. So Prosper was. I know. Got to keep them interested. Right?
I'm interested.
So Prosper. So I mentioned the statin benefit groups were mainly 40 to 75. So if you calculate an ASCVD risk and you try to plug in somebody who's over 75 or below 40, it's going to tell you if they don't meet the age category to really calculate a true ASCVD. Same with the statin benefit. And so there was a little bit of concern, because we don't have a lot of data with patients over 75, that the lowering in LDLs might increase risk for dementia. So they did the Prosper trial. It was ages 75 to 82, and they used pravastatin. And basically, the result was no difference in MMSE, mental status exam scores, at the end of the trial in these older patients. So we actually do have data up to 82 years old with statins at this point. Not past that, but we have it up to 82.
Let's see what else we have. One of the patient groups that I thought was kind of interesting that did not have benefit with statins was patients with type 2 diabetes that were undergoing hemodialysis. This is a trial from back in 2005 called the 4D trial, the New England Journal of Medicine, and they actually showed harm when you added atorvastatin 20 versus placebo in patients who were undergoing hemodialysis. So, and the harm was specifically seen in non-fatal MI, in fatal stroke. Non-fatal MI was not significant.
Yeah, definitely something to consider. And also hemorrhagic strokes. So post-hemorrhagic stroke.
Yeah, from Sparkle.
We don't like the statins there either. Just ischemic.
One of the other ones to touch on too, as far as rosuvastatin. So most of the trials you look at are dealing with the atorvastatin. One of the outcome trials that has rosuvastatin is Jupiter.
Yes.
So if you are wanting to see some data with rosuvastatin, we won't go all the way through that, but it was rosuvastatin 20 versus placebo, and they were looking at that's outcome data. They were looking at a composite of non-fatal MI, non-fatal stroke, and mortality, I believe, or it might have been a first major CV event, one of those two. But there was a difference between the rosuvastatin versus placebo, so we actually have some outcome data with that. But yeah, any other like big studies that like we need to at least mention so people can rush home and go look up?
That's all I can think of, except for the Scandinavian simvastatin survival study or whatever it is, the 5S study. I'm not super familiar with it. I just know the name because I remember Dr. Word saying it a whole bunch. But
the 4S.
The 4S.
Yeah,
not 5S.
Scandinavian simvastatin survival.
Yeah,
that's
I know
right.
the name.
Boom. That was Lancet 1994.
That was like one of the original, statins are beneficial trials, basically. And it was with simvastatin.
I think HPS was done similar, like around that same, I can't remember when that was done. It might have been later than that, but it's another, like it was like the biggest study, I think, done with outcomes and all that.
Yeah.
But yeah, 1994, good year.
Yeah. Wait, you say 1994?
Yeah, that was the 4S was 1994.
That was also my birth year, so that was a pretty good year.
Gosh, you're young.
Uh-oh.
I feel super old.
I'm dating myself now.
He's 12. So yeah, that's cool. 1994, crazy.
Yep.
We've gone quite a bit of a leap forward from where we once had one trial.
Yep.
But so yeah, that's some statin therapy, and we'll actually talk more about like individual trials and kind of go a little deeper. We just wanted to give an overview, and then we'll go from there.
Yeah.
Kind of break them down a little bit.
So that's statin. Some of that I feel like we had talked about before, but
I'm sure we have.
I could not remember where at all. I think I've even brought up that whole CoQ10 thing before, but I can't remember.
Well, now that we're about 76 episodes deep,
right?
I can't remember what we
talked about. Can't remember what we did.
I'm just kidding. I think this is episode, depending on when we post it,
right?
Will be either 18 or 19, something like that.
Yeah.
So
awesome.
Yeah, we're not that far yet.
Yeah.
You'd think I could remember.
Right. You're 2 months ago.
2 months ago. Yeah.
Cool.
But all right. Well, we will keep posting content. You guys keep letting us know what you want to hear, and definitely appreciate all the support, and the ratings on iTunes has been fantastic. We really appreciate it. But yeah, thank you so much. Please let us know what we can do to improve. And if you have any questions, want to be in the show, something like that, we will definitely take that into consideration.
Right.
We're taking applicants.
We'll evaluate your application.
It's a grueling.
We just need a 10-page essay and an interview process with our panel of experts.
Oh my gosh. I would get through half a page of that and be like, yeah, that's fine. Let them in. So, yes, we will we're going to hopefully kind of hit the ground running here soon with, we got some guests lined up that, we have to actually set dates for and all that, but we have some people that have said they want to do it.
Where we can't just text them the morning of and be like, want to record?
Yeah, like we do. Right. Zero prep work.
Yeah.
But if you can't tell.
Right.
But so I'm pretty excited about it. Some cool stuff coming up. But yeah, thank you guys so much for listening. We really appreciate it. And we will hopefully keep trying to improve it and make it more beneficial for you. But let us know what we can do. Thanks. Y'all have a great rest of the day.